Good afternoon, and welcome to the Brain and Behavior Research Foundation's Meet the Scientist monthly webinar series. I'm Dr. Jeff Borenstein, BBRF's President and CEO. Today, Dr. Jenna Traynor will present new diagnostic tools to predict symptom improvements in personality disorders. BBRF is the world's largest private funder of mental health research grants, supporting transformative discoveries in order to develop improved treatments, cures, and methods of prevention. The high quality of the research we fund is made possible by the BBRF Scientific Council. This group of 195 prominent mental health researchers reviews each grant application and selects the most promising ideas with the greatest potential to lead to breakthroughs. The Scientific Council guides the Foundation to fund creative and impactful basic, translational, and clinical research relevant to the whole spectrum of mental health. One reason that research funded by BBRF has had such a great impact is because we do not limit our focus to one illness or condition. Since 1987, the Foundation has awarded $461 million to fund more than 6,500 research grants around the world and across a broad spectrum of brain illnesses, including addiction, ADHD, anxiety, autism, bipolar disorder, borderline personality disorder, depression, eating disorders, OCD, post-traumatic stress, schizophrenia, as well as suicide prevention. Today, I'm delighted to introduce Dr. Jenna Traynor. Dr. Traynor is a clinician scientist at McLean Hospital. She was a 2022 Young Investigator. Our webinar will begin with her presentation, which will then be followed by Q&A. To submit your questions, please use the Questions tab on the control panel on your screen. Feel free to submit the questions at any time following the presentation. I'll ask as many as possible in the time allotted. And now, I'm pleased to introduce Dr. Traynor. Jenna, the floor is yours.
Thank you so much, Jeff, for the warm introduction, and hello, everyone. It's really great to be here today. I'm really excited to talk to you today about the initial findings from my research study that was funded by a 2022 Young Investigator grant by the Brain and Behavior Research Foundation and Families for BPD Research. And so my talk focuses on a discussion of new diagnostic tools that can perhaps better predict symptom improvements in people with personality disorders. And in particular, I'm going to be focusing on talking about new tools that can predict improvements in suicidal thinking. And this is because we know that suicide risk is greatly elevated in people affected by personality disorders. And also has been something that has been historically pretty hard to predict. So with that said, I'm just going to start by touching on why it's important to study predictors of suicide risk in people with personality disorders. So the bulk of these statistics on suicide and personality disorders are derived from research on people who have BPD or borderline personality disorder, because this is by far the most well-researched and characterized personality disorder to date. And so these statistics show that up to 92%, so almost all people with BPD will attempt suicide at least once in their life, but on average more than 3 times. And so this prevalence far exceeds the prevalence of suicide attempts in the general population. And ultimately, 1 in 10 people with BPD will die by suicide, which is a really staggering statistic and really speaks to the need for research in this area. We also know that even other personality disorders like narcissistic personality disorder, for example, are also associated with a greater risk of not only attempting suicide, but having a very medically serious suicide attempt. And so these statistics are actually associated with this kind of cascading clinical problem. So, for example, about half of mental health care providers report that they don't feel confident that our currently available assessment methods are adequate to screen for, detect, and predict the risk of suicide in people who have personality disorders. And importantly, they also report that they do want new innovative clinical tools to better manage and predict the risk of suicide in their patients. Now, because of their lack of confidence in our current screening measures, many clinicians actually report that they try to avoid treating personality disorders altogether, which is in turn associated with a lack of clinicians that are available to treat people with personality disorders and really long wait times for those really limited spots. And while people who have personality disorders are waitlisted, they often present to emergency care experiencing suicidal ideation and suicidal crisis. So there's really this kind of cascading, kind of domino effect of a lack of research in this area. Now, we also know that although there are many different types of treatments available for people who have suicidal thinking, that treatment doesn't work for everyone. So some people do get better, of course, but for others, suicidal thinking can persist even after treatment ends. And we don't have a lot of information or data about why this is the case. So there's definitely more research that is needed to understand why some people respond to treatment and other people don't respond. So for example, if we look at the available treatments for suicidal people who have borderline personality disorder or BPD, these treatments all vary in how specialized they are, right? So some are especially designed to treat borderline personality disorder, like dialectical behavior therapy and mentalization-based treatment, whereas others are more general. These treatments also vary a lot in their length, right? So someone who's having suicidal thoughts could call a mental health crisis line and speak to someone for 10, 15 minutes, and that could be very effective, whereas other people need a year or more of long-term intensive specialized psychotherapy. And then these treatments also vary in their intensity. So some of them, for example, are weekly, like a 12-week outpatient treatment program, whereas others are more intensive, like a brief 7-day intensive day hospital treatment. So there's a lot of variability in terms of the length and intensity and speciality of these treatments. Now, importantly, research suggests that not all people with personality disorders need long specialist treatments to experience improvements in suicidal thinking. So some people might actually do really well, for example, in a brief intensive partial hospital program. And so a big focus of my research is to try to understand patient characteristics that will tell us more about which type of treatment any one individual needs. And so traditionally, the first clue to understanding what type of treatment someone needs is to look at what symptoms they have or what diagnosis they have. And so the Diagnostic and Statistical Manual, which is, commonly referred to as clinician's Bible, this is what psychologists and psychiatrists in North America have always used to assess and diagnose mental health disorders. So the DSM-5, which is the latest version of the DSM, lists all of the possible symptoms of any disorder and says that if someone is reporting enough of those symptoms, that we can then diagnose them with that disorder. So to use BPD as an example again, the DSM-5 lists these 9 possible symptoms of BPD and says that if somebody has at least 5 of these symptoms, then we can diagnose BPD. But if we take a look at these 9 BPD symptoms, we see that they really vary quite drastically in their nature, right? So some are kind of interpersonal in nature, so, frantic efforts to avoid abandonment and up and down kind of tumultuous relationships. We also see on here there's identity concerns and impulsive or dangerous behaviors, as well as self-harm and suicide attempts, and then kind of all the way to emotions and feeling empty. So there's a big span of different types of symptoms that all belong kind of in this DSM-BPD bucket. But because any one person with BPD only needs to have 5 of these possible symptoms or nodes, this means that if we take a look at different people who are all affected or diagnosed with BPD, each person is going to have a different set of BPD symptoms. So for example, we could have somebody who might experience a lot of problems with anger or emotional instability. And then we might see another person who has BPD who may not have either of those kind of emotional dysregulation symptoms and instead tends to present with a lot more suicidal thinking or a lot more interpersonal kind of turmoil. And then we might have like a third person who will have an even different set of symptoms than the previous two. And this is typically what we see when we see people who've been diagnosed with BPD. There's a lot of variability in the presenting problems across people who have the diagnosis. And in fact, because of the DSM-5 rule that somebody only needs to have 5 of 9 possible symptoms, it's possible that 2 people who have BPD may only share 1 symptom in common. So for example, these 2 people here only share tumultuous relationships in common, but otherwise, if we take a look at their symptom presentation, it's actually quite different. So they're really kind of struggling with different things. Now, in fact, when we look across all of the possible combinations of the 5 or more BPD symptoms that somebody needs to meet criteria for the diagnosis, there are actually 256 possible combinations of BPD symptoms that someone can have. So each one of these colored squares here, just so we can visualize the extreme variability, each one of these colored squares represents one person with BPD who has a different set of BPD symptoms than the next person or the next colored square. Now, that's kind of fascinating, but if we also keep in mind that borderline personality disorder is generally found to be comorbid or co-occur with at least one other psychiatric disorder. And that other psychiatric disorder may also present with very strong variation in symptom presentation from person to person. So this raises really important questions and actually challenges that are related to this kind of traditional way of assessing personality disorders in the DSM-5. And it turns out that, you know, a lot of scientific questions can be raised by this variability. So across these 256 different people with BPD who each have a different combination of symptoms, some of the questions that come up for me are, what disorder, right, or what construct are we really studying when we have a group of people who all have BPD, but they all have different symptoms? Who is going to get better with treatment for BPD? And I've put that in quotations because what are we really treating, right, if there's so much variability? Which type of treatment does any one of these individuals need to get better? And who needs more intensive treatment? Who needs longer treatment? Who's going to recover from BPD? Who's going to stop thinking about suicide after they get treatment? So there's a lot of questions that come up related to this really strong variability. Now, it turns out that there is actually very little about these specific BPD symptoms in the DSM-5 that can give us clues about who is going to respond to which type of treatment or any treatment at all. And it turns out that this is actually the case for most personality disorders. So there's just too much kind of variability in the way that personality disorder symptoms can present from individual to individual to really predict very much about that person by using their DSM-5 diagnosis alone. And so knowing this information really made me kind of take a big step back and take like a bird's eye view on This idea of assessing symptoms and to really think about like, what is the point of assessing symptoms and what is the point of a diagnosis? And for me, the point of a diagnosis is to provide us with a roadmap to recovery, right? We want to get from point A, where we understand somebody's set of symptoms and their diagnosis, and that will inform kind of the pathway to B, which would be to recovery. Now, there are really important problems, though, with our traditional approach to assessing personality disorders. And this is due to that really high variation in different symptoms across different people. So to continue with the example of BPD, it turns out that the threshold of 5 of 9 symptoms that are required for a BPD diagnosis is actually quite arbitrary, right? Because we know that somebody who comes in who has 4 very severe BPD symptoms, or even 3 very severe BPD symptoms, might need more help or support than someone with 6 mild BPD symptoms, or 7 or 8. So the number, this arbitrary cutoff of 5 or 9, doesn't really make a lot of sense when we think about how we're going to treat this person. There's also often a lot of disagreement across different clinicians and assessors about whether somebody should actually be diagnosed with BPD or another personality disorder. And even the BPD diagnosis itself doesn't really tell us a whole lot about how somebody's going to function now or in the future, and whether they're going to respond to treatment, right? So we know actually that there are new meta-analyses that have come out since around, I think, 2017 that have shown us that about half of people who attempt BPD therapy either drop out early from the therapy and don't get better, or they just don't respond to the treatment. So they're still experiencing significant suffering even though they've completed the treatment. And then finally, as I mentioned before, we also know that people who have one personality disorder often meet criteria for other personality disorders at the same time. So there's tons of overlap between these different kind of diagnostic buckets that are in the DSM. So this information has catalyzed a gradual but important shift in the way that we're starting to view and assess and think about personality disorders more broadly. And this shift is now gaining momentum in the field of psychiatry and psychology. So traditionally, the DSM-5 says that we have 10 separate personality disorders that are each supposed to have distinct symptoms that are, fit neatly into these different diagnostic buckets, right? So we have borderline personality disorder, we have paranoid personality disorder, dependent personality disorder, and these are all supposed to be different categories. But recently, there has been a shift away from seeing personality disorders as separate and more towards measuring what is actually shared across all of these personality disorder categories. So this is like a totally new way of thinking about what constitutes or what makes up a personality disorder. And so some of the kind of shared traits in personality disorder we can see are, for example, a tendency to experience negative emotions like anxiety and fear. That trait is kind of shared across almost all of these personality disorder categories. So they all have that in common. The tendency to act rashly without much forethought, that's shared, right, across borderline, antisocial, and maybe histrionic personality disorder. Similarly, the tendency to avoid getting close to other people is sometimes seen in borderline personality disorder, also antisocial, schizoid, paranoid, etc. So it turns out that if we shift our minds to looking at what is shared across personality disorders, it turns out there's actually a lot. And so this information, this kind of framework of looking at things dimensionally rather than using categories, is this kind of totally new way of thinking about things. And the National Institute of Mental Health, the APA, and WHO have all released new frameworks recently for assessing and viewing kind of what is shared across these personality disorder categories rather than trying to distinguish them or separate them from one another. Now, during my postdoctoral fellowship in 2019 with Dr. Anthony Rocco in Toronto, Canada, my colleagues and I were invited to write a paper on this topic, commenting on the possibilities of this new framework, this new dimensional framework for research on personality disorder. And this is actually what got me thinking about the research that I'm going to share today, which focuses on this new way of assessing symptoms. So I kind of want us to maybe throw away everything we've learned about personality disorders so far and really put on kind of a new hat and being open to thinking about a new way of assessing things. So this new approach has actually already been adopted by the ICD-11, which is the diagnostic system used basically everywhere else in the world except for North America. And it proposes that instead of placing individuals into separate personality disorder categories, that we can actually glean much better and much more precise information, more reliable information, by measuring the extent of impairment in these areas of self and interpersonal functioning. So, according to this new way of assessing personality disorders, impairment in self and interpersonal functioning is what is thought to be at the core of personality disorder more broadly. And so the 4 key areas of impairment that we can assess to see if somebody might be having problems that are consistent with personality disorder are here. And with this new system, I just want to emphasize again, because I know it's very different, we aren't saying that anyone has a specific type of personality disorder. We're just measuring the severity and the extent of problems in these 4 different areas that tend to be shared areas of impairment. So the first area is empathy. And we know that people with personality disorders tend to have problems taking the perspective of another person or really kind of putting themselves in somebody else's feeling shoes. Similarly, we know that troubles with intimacy and feeling safe in close relationships, trouble sustaining meaningful close relationships is often reported by people who have personality disorders. And so these 2 areas of impairment, empathy and intimacy, together comprise this interpersonal component of personality disorder. Now, we also have these 2 other areas here, identity and self-direction. And so with identity, people with personality disorders tend to have difficulty kind of creating a coherent sense of self. Right? So sometimes they would report not really knowing who they are at their core or identifying with kind of really drastic or different incoherent stories of themselves. And similarly, there's issues in self-direction. So having trouble setting goals, following through on goals to create a life that is really meaningful and fulfilling. And so together, these 2 final areas here of impairment, identity, and self-direction, they comprise the self-functioning component of this new system. So when we talk about self-interpersonal impairment, that's what we're talking about. And so this new way of assessing personality disorders actually says that in any one of these 4 areas, someone may have no impairment at all the way to extreme impairment. And this is important because we're not only getting binary information about the presence or absence of these 4 traits, but we're also getting information about how severe these symptoms are on a dimensional scale. And this is a really key aspect of this new approach that differs from our old kind of yes or no binary diagnostic system. So here we're collecting more precise information about the severity of impairments in these problem areas. And so the catalyst actually for my Brain and Behavior Research Foundation funded study that I'm going to talk about in a minute was actually work that I did as a postdoc in 2019 with Dr. Anthony Rocco from U of T Canada and a visiting scientist, Dr. Johannes Breguet from the University of Basel, Switzerland. And with this first study that we did, we wanted to see whether there was a relationship between these newly defined aspects of personality disorder impairment and functioning in the brain using functional magnetic resonance imaging. We also wanted to know whether newly defined aspects of personality disorder showed stronger relationships with brain function compared to our kind of traditional categorical DSM-5 assessment method for personality disorders. So for this study, we collected data from 45 inpatients who were beginning treatment at the university hospital, and all of our participants in this study had met criteria for borderline personality disorder, but the majority of them also had at least one additional personality disorder diagnosis, as is usually the case with personality disorders. There's a lot of shared variability. And everyone first completed a resting state fMRI brain scan. So a resting state fMRI scan is using MRI to measure brain activity while the participant simply just rests with their eyes open. So they're not doing any particular type of task or paradigm while we have the fMRI taking a picture of their brain. And we know that even during rest, when we're not really doing anything in particular, our brain is always active. So we can definitely still derive really important information about brain function at rest. And then after they had their fMRI scan, each participant completed 2 types of assessments. So the first assessment measured personality disorder symptoms in this new way by assessing the extent of impairments in self and interpersonal functioning. And then we also used a more traditional categorical DSM-5 approach by just measuring the severity of BPD symptoms, because everybody in the study did meet criteria for BPD. Now, in terms of the areas of the brain that we explored in this study, the MRI literature actually tell us that people with personality disorders and people actually who have non-personality disorders show altered patterns of brain activation in 4 different neural networks. And each of these neural networks serve a different function. And so the 4 networks that we were interested in exploring in this study were this network over here on the left, which is actually called the default mode network, which is thought to be really heavily involved in reflecting on ourselves, so kind of introspecting on our own feelings and experiences, and also social cognition, so also relating how we relate to other people. So I've labeled this one as reflect and relate. We also looked at the salience network, which we know helps us to kind of scan and detect and filter information in the environment in order to create meaningful experiences. We also looked at this network that helps us to think and perform, kind of performing cognitive tasks or kind of higher order executive functioning skills. And this is called the frontal parietal network. And then finally, of course, we looked at the frontal limbic system, which is our primary network involved in experiencing and feeling emotions and also learning to regulate our emotions. So we were really interested in the connections between these different areas within these networks while the participant was just at rest. And so what we found was actually only the new way of measuring personality disorder symptoms was associated with brain connectivity. So specifically, we found that in this group of 45 inpatients with BPD and other personality disorders, those people who had greater impairments in actually that subcomponent of the dimensional measure empathy, so people who had greater impairments in empathy, which is the ability to take the perspective of another person, had stronger functional connections between 2 areas of the limbic system, which is really the brain's emotion center, the amygdala and the parahippocampal gyrus. So in particular, we found that strong connectivity between the amygdala and an area in the limbic system called the parahippocampal gyrus, which is right beside it, was associated with greater impairments in empathy. Now, on the other hand, using our traditional assessment approach, where we just measured the severity of symptoms of BPD, this was not associated with any patterns of brain function in the study. And so what we concluded from this initial study was that this new way of assessing symptoms, these new diagnostic measures, may be able to better capture or better quantify impairment or information about how the brain is working in people with personality disorders compared to our traditional DSM-5 categorical approach. So these initial findings really inspired me to submit a grant proposal to the Brain and Behavior Research Foundation, because my thinking was, if this new way of assessing personality disorder symptoms was able to capture a stronger brain signal, could this assessment method also give us more reliable or precise information about which people or which patient characteristics are best suited to different types of treatments for people who have suicidal thinking, which is a main focus of my research. And I also wanted to know, can we use this measure to proactively identify then people who are more or less likely to respond to specific treatments for suicidal thinking? Now, if I could discover these things, my thinking is that this would have a really important clinical impact, right? Because then we could better streamline different clients into the proper treatments for them and increase the number of people who respond optimally to them. So these are kind of the primary aims of my study that I'm going to present now, which is, as I mentioned, funded by the Brain and Behavior Research Foundation and Families for Borderline Personality Disorder Research. So we are recruiting participants who are beginning treatment at our behavioral partial hospital program at McLean here on the right. Unfortunately, I couldn't find a color picture, but this is a black and white picture of the treatment building. And the partial hospital sees a lot of people who are experiencing suicidal thinking. And the program runs daily from 9 in the morning until 3 in the afternoon, and actually includes a lot of different things. So while patients are being treated, they're getting individual therapy, they're getting group psychotherapy and skills training, as well as medication and case management. And if we think back to that slide where there were all those different types of interventions, this one kind of falls in the middle because it's actually very brief. So the typical length of stay is only 12 days, but it's very intensive because people are there for 6 hours for all of those 12 days. And in the spirit of this new dimensional way of assessing symptoms, participants in this study actually do not need to have any specific psychiatric diagnosis to participate. So all of our participants do have psychiatric diagnoses, but they don't need any one in particular to participate in this study, because if you remember, we're not thinking about diagnosis in this study in terms of different categories. So we're recruiting a truly transdiagnostic participant sample, and this means that participants in our study are often presenting with moderate to severe mood, anxiety, substance use disorders, personality disorders, trauma, OCD. So we really have a very wide range of clinical presentations. Now, one of our eligibility criteria are that everyone in the study needs to be endorsing suicidal thinking to some extent. So we have participants who have passive suicidal or fleeting ideation, all the way to people who experience more intense suicidal thoughts. And so in terms of what we do, within the first few days of their treatment at the BHP, we measure in each participant, firstly, the presence and severity of these 4 areas of functioning that are aligned with this new dimensional framework for measuring personality disorder. So we actually use a self-report measure that was designed by Leslie Morey in 2017 called the Levels of Personality Functioning Scale. And so this asks the participant to report on the presence and severity of problems in empathy, intimacy, identity, and self-direction. And it probably takes about 20 minutes to complete. And then we also, of course, are measuring symptoms using our traditional method of assessment in the DSM-5. So these binary kind of categories denoting the presence or absence of various disorders like BPD, antisocial personality disorder, mood and anxiety disorders, etc. And then at intake, so within the first few days of their treatment, everyone also completes a 12-minute resting state fMRI scan to measure brain activity across those 4 neural networks that I was talking about before. So after completing these tasks at baseline, everyone also gets a baseline assessment of their symptoms. So we look at whether they have the intensity of their suicidal thinking, because everybody does have some suicidal thinking at baseline, as well as their depression severity and quality of life. And then we measure these symptoms again right before they are discharged from the hospital, so at post-treatment. And then we ask participants to come back 3 months later for a follow-up visit where we get a final reading on these symptoms. So we actually have 3 different time points that we see them at. And so just to reiterate, my primary research aim here is to ask, can this dimensional measure tell us more about these trajectories of mental health symptoms over time than a categorical measure can? And if we add in or combine data from the brain scan with these 2 different types of assessment approaches, can that tell us even more about who is going to benefit? So who is going to experience a reduction or improvement in these symptoms from pre to post-treatment in the intensive partial hospital? So in terms of my hypotheses, so the first thing that we were thinking about, if we were just going to look at the trajectories of symptoms across treatment, we first hypothesized that individuals would experience an improvement in their symptoms across the partial hospital treatment program. And importantly, we also hypothesized that measuring symptoms using these 2 different methods would give us different information about whether someone was going to continue to experience suicidal ideation at post-treatment or not. So essentially looking at treatment response in the area of suicidal thinking. So in particular, we hypothesized that more severe impairments in these areas of self and interpersonal functioning would predict more suicidal thinking at post-treatment. So people with more personality disorder impairment would be more suicidal at the end of the treatment, versus using this more traditional diagnostic approach, we predicted that this wouldn't really tell us a lot about who's going to experience a reduction in suicidal thinking at post-treatment, simply due to the variability, right? The strong variability across all of these disorders. It's just, we didn't predict that it would be capturing enough to really say anything prognostically about suicidal ideation. So now I'm going to present on what we found so far. So first of all, when we look at how symptoms are changing across the partial hospital treatment, so is the treatment helping? The answer is yes. So on average, these preliminary findings, and I should say they're preliminary because this is only the first 28 people who've been enrolled in the study and completed their post-treatment visit. We still have a number of people who are scheduled to come in for their 3-month follow-up and a number of people still being recruited into the study. So these are very early numbers, but these early numbers are showing that individuals in the program are experiencing a reduction in suicidal thinking from intake, which is right here, to discharge, usually 12 days later. And this reduction in suicidal ideation remains significant at the 3-month follow-up time point. Similarly, we can also see that depression is improving from pre to post-treatment, and at follow-up, it's kind of staying lower. And then quality of life, of course, is going up, which is a good thing, right? So more quality of life over time. So this is good news, right? I think sometimes there's a myth in psychology or psychiatry that longer treatment is needed for people to make these types of really meaningful, important treatment gains. And our data, our preliminary data are saying that perhaps this isn't the case. Like an intensive brief partial hospital is really meaningful to help people experience these important reductions in symptoms. And I do want to emphasize, of course, that this is early days, so this is preliminary data. Moving forward now, I'm going to stay focused on talking about what is predicting suicidal ideation at post-treatment. So because this is one of the primary questions that we're interested in, so I'm just going to stay focused mostly on talking about this one moving forward. So when we look at what is predicting the presence or absence of suicidal ideation at post-treatment, what we found, as hypothesized, is that the strongest predictor of whether someone is still having suicidal thoughts at discharge were scores on assessments that measured symptoms in a new way, so dimensional symptoms. So in other words, the total impairment score, or the sum of problems in these 4 key areas, was predictive of the presence or absence of suicidal thinking at post-treatment. Now we're finding a marginally significant effect here. I think that this is because we have a lower sample size at the moment, but this is showing up as a predictor of suicidal thinking at post-treatment. On the other hand, when using scores that were derived from the traditional way of measuring mental health disorders in the DSM-5, we found that this does not predict the resolution of suicidal thinking at post-treatment. So when we looked at, number of these disorders as well as the severity of BPD symptoms, neither one of these were significant predictors of suicidal ideation. So although preliminary, this is what we hypothesized, right? And it's very promising. And it suggests that this new way of measuring symptoms in self and interpersonal impairment might actually be better or more reliable for predicting who is best suited to receive a partial hospital intervention to target suicidal thinking. Now, as I mentioned, if you can break down these areas into 2 subcomponents, right? So we have our interpersonal subcomponent score, which represents the extent of impairments in empathy and intimacy. And then we also have our self-impairment score, which represents the extent of impairments in identity and self-direction. And when we actually followed up on our previous finding, and when we looked at whether both or only one of these subcomponents, is it the self or the interpersonal score that is predicting the presence or absence of suicidal ideation at post-treatment, what we found was that actually it's only the self score, the self domain, that is predictive of the persistence of suicidal ideation across treatment. And so if we actually just take a look for a second at some of the questions of the self-report measure that pertain to self-functioning, we can see that people who didn't respond to the partial hospital treatment, or in other words, who remained suicidal at post-treatment, tended to endorse these types of items. So I don't waste my time thinking about my experiences, feelings, and actions. I have little understanding of how I feel or what I do. Life is a dangerous place without a lot of meaning to it. I have difficulty setting and completing goals, and I have trouble deciding between different goals. So these are examples of some of the items from the measure that we used. And so when we look at this, we can actually see that it's looking like persistent suicidal thinking across treatment appears to be associated with people who enter treatment having difficulty getting in touch with their own feelings, their own desires, and therefore kind of having this experience of life as purposeless or meaningless. And in turn, then having trouble setting goals and knowing what they want, and creating a more purposeful life. And when we think about the function of suicidal thinking, there's actually a lot of research to suggest that suicidal thinking is a way to regulate emotional pain. It's a way to regulate internal pain or feelings of emptiness by kind of fantasizing about a solution, right? A different way out or a way to reduce the pain, even if it's really upsetting. And so I think that at face value, these findings really make a lot of sense because, you know, people who are struggling to develop a relationship with themselves are experiencing more persistent suicidal thinking, even after an intensive partial hospital intervention. Now, finally, we've also taken a look at our resting state fMRI data to begin to explore whether there is a relationship between brain function and scores on the new dimensional diagnostic tool, as well as scores on the traditional DSM-5 assessments that we did. And so far, similar to the results actually that I presented near the beginning of this talk, what we're finding so far is that only scores on the new dimensional diagnostic tool, but not scores on the more traditional DSM-5 categories are associated with patterns of resting state brain function. And so in particular, what we're seeing is that, again, these impairments in the self-functioning domain these are the only scores that are showing significant associations with two clusters of functional brain connectivity. So how different regions of the brain work together or are functionally connected. And these clusters are actually thought to be heavily involved in decision making and in self-reflection. And so the first cluster that we're seeing coming up as significant actually involves an area of the brain that plays a really central role in decision making from that task on network that I showed you before. So the posterior parietal cortex is really involved in decision making and maintaining attention. And also what we're seeing come up in this cluster are two areas of the brain that are thought to be really, really core to understanding ourselves and other people. So the angular gyrus, which is right here, and the part of the hippocampus called the parahippocampal gyrus. So again, the parahippocampal gyrus is coming up as a really important candidate fMRI marker. Similarly, the second functional connectivity cluster involves an area of the prefrontal cortex, the lateral prefrontal cortex, that we think is involved, again, in kind of these task-on functions like planning, problem solving, paying attention to the environment. And we're seeing that this is significantly connected, again, with the parahippocampal gyrus. And so I just want to say one thing about the parahippocampal gyrus, because particularly in personality disorders, there's some literature coming out to show that the parahippocampal gyrus might be somehow involved in what we call rational updating about our beliefs about ourselves and other people. So the ability to kind of like if I'm rationally updating it, I have an ability to flexibly change my beliefs about myself and other people as I walk about the world and go about my life and gain new information. I can update my beliefs according to that information. And so I just think it's interesting that the parahippocampal gyrus is kind of continuously popping up in this work. So overall, this slide shows that impairment in self-functioning, so worse identity and self-direction, is associated with stronger functional connections between these areas in these two clusters. And I should say, in this case, stronger connections doesn't indicate better connections. So stronger connectivity is not better connectivity. There are actually many hypotheses about why stronger connectivity might be associated with actually poorer behavior or poorer functioning or psychopathology. You know, for example, one of the hypotheses is that the brain may be overcompensating in some way for this poor self-functioning, right? Or it might take stronger functional connectivity in those who are really most impacted by self-functioning impairments. So there are many reasons why this may be the direction that it is. And those are just some, initial ideas. And I'm sure as we continue to recruit participants into this work, hopefully this finding will strengthen and then we can explore it a bit further. But these are the initial findings, and they really make sense, right? Because they're hitting on the neural networks that are thought to play a role in self-understanding and making decisions about ourselves. So to finish off my talk today, I just want to spend a few minutes discussing the next steps for this research and also talking about how these findings may impact the mental health field. So in terms of the next step, so of course I've showed you very preliminary data from our first 28 participants. So currently we are still recruiting participants into the study, and we are running additional analyses to explore whether there are actually thresholds of impairment in self-understanding or self-functioning that are related to the persistence of suicidal thinking across treatment. So in other words, our preliminary findings so far suggest that on average, more impairment in self-understanding is associated with more persistence in suicidal thoughts. But one question that I have is, at what severity of impairment in self-understanding does one become less likely to respond to the partial hospital treatment, right? So is it even mild impairments in identity and self-direction that are associated with persistent suicidal thinking? Or is it just those individuals who have very severe impairments that are less likely to respond to the intervention? And as I mentioned before, one of the strengths of this new dimensional measure is that it actually does give us this type of very precise measurement information to be able to answer questions like this. And then also we want to take the brain imaging findings, the functional connectivity values, and see if adding them into our prediction models can even further improve our ability to predict suicidal thinking at post-treatment. So in other words, can combining the scores on self-report measures with brain imaging markers tell us more about information about who is likely to respond to the treatment? So those are kind of the two next steps that we're doing with our analyses. And then I just want to end by briefly touching on how these findings may make a clinical impact. So what is the actual tangible or kind of like translational value of these findings? So to reiterate our main finding, it is that suicidal people who enter the partial hospital treatment with more impairments in self-functioning tend to remain suicidal at post-treatment. So self-functioning appears to be a more precise measure that may have better prognostic utility for predicting response to the partial hospital intervention. But on the other hand, the presence or absence of DSM-5 diagnoses like BPD or depression, these separate diagnostic categories so far in our analyses are not showing up as significant predictors. So as we continue recruiting for the study and add more participant data to the analyses, if this finding holds, then it may be the case that measuring self-functioning rather than assessing people for different types of disorders, as we've traditionally done, may be able to give us a better idea about which people who are suicidal will respond to the partial hospital treatment. So with that, I would just like to again thank the Brain and Behavior Research Foundation and Families for Borderline Personality Disorder Research for their generous funding for this work, as well as the Canadian Institutes of Health Research that funded the small study that I presented on in the beginning. So thank you, and I think I will open it up to questions now.
Great. Well, Jenna, thank you for the work that you're doing and an excellent presentation on such an important topic. The statistic that's so striking is the level of risk for people who have borderline personality disorder, other disorders, and the increased risk for suicide attempts and completed suicide. So, extremely important. I'd like to ask you to speak a little bit about an important issue. People often have the misperception, the incorrect belief that if you ask somebody about suicide risk, suicidal thoughts, you may be putting them at greater risk, when in reality you could be helping to save their life. And I'd like you to speak about that for our audience.
Sure. Yeah. Thank you for bringing that issue up. I think it's really, really important. And I think you hit the nail on the head when you said that actually speaking to somebody who's suicidal might actually help to save their life. So we know that there is no research that exists to show that talking to somebody about their suicidal thinking or plans is going to increase their risk of suicide. We actually know that most people who are thinking about suicide experience some sort of shame or embarrassment about what they're thinking or experiencing. And so having someone who's coming to them in a very kind of caring, but also, very direct and matter of fact way, who can speak very directly to them about what their concerns are. For example, saying like, hey, I've noticed you've been really down lately, and I'm just, wondering if you're feeling okay, or, even asking like, are you having thoughts of ending your life? Those are really validating and important and caring questions to ask directly, to check in on our clients, our family members, our friends. And the more we actually talk about suicide with somebody who is suicidal, the more supported they feel, the more we can help them to plan for ways that they can stay safe, and the better chance they have of being able to continue to live. So yes, that's a myth that talking about suicide will somehow increase suicide risk. That's just not true.
Yes, good. Excellent summary of that. And let me just ask as a final question, and you sort of made mention, talk to us about safety planning, about steps that people can take to decrease the risk of actually attempting or completing a suicide.
Mhm. Yeah, so it's really good to have a safety plan in place because when suicidal urges increase, oftentimes the part of our brain that can help us problem solve and help us have access to safety and resources kind of shuts down. And the part of our brain that is overwhelmed with emotions or fear or shame is really in the driver's seat. So if we don't have a safety plan kind of already made beforehand, it could be really difficult in times where suicidal urges are getting higher. Um, and so, so there's a lot of things to put on a safety plan. I think one of them is um, who in your life can you trust to talk to about this? So, what is the name of one person who you could turn to talk to about this? So, is that a family member? Is that a friend? Do you have a therapist? Is it somebody who you're friendly with at a coffee shop? It could really be anyone, but I think research shows that having at least one support person um, is protective. And so if you start to feel unsafe, you could get in touch with that person. Sometimes people they're going through a period of their life where they don't have one person that they could name. And so that's where having a list of mental health resources, mental health crisis lines, suicide crisis lines, their numbers on the safety plan is also really, really important. So just having somewhere to turn to immediately if you start to feel unsafe is really important. And then also, we talk about kind of getting rid of access to means to attempt suicide. So if there's something in your home or you have access to something that you know is dangerous and might be more likely to be used if you do become more suicidal, proactively making sure that that's not in your home getting rid of it, throwing it in the garbage when you're in a grounded and regulated state, giving it to a friend to hold on to. There's really creative ways that we can do to kind of reduce access to means. And then I think the third thing is having skills that you know are going to help ground you and get you through, kind of ride the wave of that suicidal urge. So, whether that is distracting by watching really funny comedy movies, or playing with your dogs, going for a walk with your dogs, calling a friend and going for a coffee, doing some deep breathing or meditation, or going for a really hard long run. There's tons of different skills that we know that are really effective when we experience suicidal crisis, because kind of similar to addiction, suicidal urges will go up and then they will go down. So if you have a set of skills that you can implement while they're up, that you can use to kind of reground yourself, that's also something to write down onto the safety plan. And then I think I know it's 3 o'clock, but I just think the last thing that I'll mention that I think is really important, especially with data coming out about police brutality and people of color, that it's really important to know where your closest emergency department is, so that you can find a way to get to the emergency department by an Uber or a taxi cab or a friend, or call a mental health crisis line, and just kind of finding ways to access services without having to call the police is something that I also recommend for everyone, but especially for people of color, given some of the very disappointing statistics that we have seen lately. So, yeah.
Great. Thank you, Jenna. Excellent overview of such important information for people. So thank you.
Thank you so much.
Um, yes. So I also, in addition to thanking Dr. Traynor, I also want to thank everybody who joined us today, and ask people to please consider making a gift to BBRF. 100% of every dollar donated for research is invested in our research grants. We're able to do this because our operating expenses are covered by separate foundation grants. This means that when you donate a dollar for research, that dollar goes directly to the scientists. To make a gift, please visit bbrfoundation.org or call at 1-800-829-8289. This webinar has been recorded. If you've missed any portion or would like to share it, please visit the events and webinars page on our website. And please join us again on October 8th at 2 p.m. Eastern Time, when Dr. Sarah Yip, an associate professor of psychiatry at Yale School of Medicine and the director of the Yale Imaging and Psychopharmacology Lab, will present Toward Brain-Based Prediction of Recovery: How Neuroimaging Can Help Combat the Substance Use Epidemic. Thank you, and remember, together we can dramatically improve the lives of those living with mental illness and enable more people to live full, happy, and productive lives. Take care.